Hi, so today we will be talking about remplissage as an adjunct to Bankhart's repair in shoulder instability. So first we need to understand the components of instability. Essentially, there are two components: a soft tissue component, which is composed of a labral tear in the glenohumeral ligaments, or sometimes in the elderly, it's a rotator cuff tear. The other is the bony component of instability. It could involve either the glenoid side or the humeral head in form of a Hill-Sachs lesion. So essentially, we need to address and quantify both the bony as well as the instability soft tissue components to reduce the failures of our surgery. And that is the crux of today's talk. So before we move on further, I would like to share something about the glenoid tract, because this is a concept which has helped us quantify and establish the bony component of shoulder instability. So what is this glenoid tract concept all about? As you could see in the picture on the top right, that purple zone is the glenoid contact area on the head. And this is called the glenoid tract. And this area shifts from inframedial to supralateral as the arm is moved to abduction, external rotation, or the Aber position. This was first described in the year 2007 by Eiji Itoi from Japan. Now, how does it work? See, the Hill-Sachs lesion, which forms part of that purple area in the previous picture you saw, could be essentially of two types. One is the non-engaging Hill-Sachs or the on-track Hill-Sachs, which is not so dangerous, and the other, which is the engaging Hill-Sachs or the off-track Hill-Sachs, which is dangerous and contributes significantly to instability. I'll play this video for you so you can figure it out. So as the arm is taken up in the Aber position, if the Hill-Sachs is like this and does not engage with the glenoid, it's fine. It's non-engaging on track. But in case of a glenoid bone loss like this, the Hill-Sachs tends to engage, and this is the engaging or the off-track Hill-Sachs. And this is what we need to quantify and address in our surgery, without which a soft tissue operation is likely not to succeed. So in 2014, January, Eiji Itoi and Steve Burkhardt came up with this paper. It's a lovely paper. You can have a read. It says evolving concept of bipolar bone loss and the Hill-Sachs lesion from engaging, non-engaging to on-track, off-track. So this is the first time the on-track, off-track concept was propagated by Itoi and Burkhardt. And what does it do? It's a radiographic and arthroscopic method which can assess if the Hill-Sachs lesion will engage on the anterior bony rib of the glenoid. Now, the rule book says that you need to do something about the Hill-Sachs lesion if it engages or if it is off track. So in what is it that you do? Most commonly done thing is to add remplissage to a Bankhart's repair if a Hill-Sachs will engage. What is remplissage? Literally the term means filling up. So what do we do here? We fill up the Hill-Sachs defect with the posterior capsule and infraspinatus tendon. And that's what we're going to look at in the next few minutes. So moving on to the glenoid tract concept, exactly how it works. Now this area, which is the contact area, corresponds to 83% of the best fit diameter of glenoid, and a corresponding area on the humeral head is called the glenoid tract. And this is a colorful picture which explains it. Now from this 83% of the best fit circle, we need to deduct whatever anterior glenoid bone loss has occurred in the said patient and thereby get the exact measurements. On the other hand, there is something called Hill-Sachs interval which needs to be calculated on a Hill-Sachs lesion. What is the Hill-Sachs interval? If you look at the last picture, the rotator cuff tends to insert on the humeral head on this line called L1. Then there is a small bony bridge which is marked as BB between the rotator cuff insertion and the lateral end of your Hill-Sachs lesion. Finally, on the medialmost side, there is a point marked by the line L2 on which the Hill-Sachs lesion ends. So HSI or Hill-Sachs interval is the distance between the medialmost end of your Hill-Sachs lesion and the lateral insertion of the rotator cuff on the humeral head. So it's essentially the Hill-Sachs plus the bony bridge put together, which forms the HSI. So that is the concept which we are going to talk about, and also it will be more detailed in the next slide. So this is how it works. You make a best fit circle on the glenoid and you 3% of that figure. Typically, best fit circles in our population are in the range of 22, 23, 24 mm or so. You take 83% of that figure, whatever the best fit circle says on the CT scan, and then you subtract the small d, which is the amount of anterior bone loss. This is your glenoid tract. And on the humeral head side, you calculate the distance between L1 and L2 on this top right picture. And this will give you the Hill-Sachs interval. Now, if the Hill-Sachs interval is greater than the glenoid tract that you have calculated, then this is an off-track lesion. If the Hill-Sachs lesion and the bony bridge together made as HSI or the Hill-Sachs interval is less than the glenoid tract, then you are on track. The same has also been demonstrated in this MRI scan pictures, which you can figure out. The treatment algorithm proposed is glenoid defects of more than 25% will need some bony surgery. Typically, this is done in the form of a Latarjet procedure. Glenoid bone defects less than 25% could be essentially of two types. One in which the Hill-Sachs lesion is on track or the HSI is less than the glenoid tract. These are the on-track lesions in which, as recommended by Burkhardt and Itoi, you can get away with only an arthroscopic Bankhart's repair and you will be successful. On the other hand, the second group is where the Hill-Sachs interval is bigger than the glenoid tract. These are off-track or engaging Hill-Sachs lesions. And these are the ones where you have to do something about the Hill-Sachs, as in do a remplissage along with an arthroscopic Bankhart's repair. On the other hand, number 3, number 4 refer to more than 25% glenoid bone loss, where you have to augment bone. And if it is on track, you only do a Latarjet. And according to the algorithm, if it is off track, you need to do a remplissage plus Latarjet. Practically speaking, this is a fairly large major undertaking. Few people would combine remplissage with a Latarjet. I would probably not do it. The other point to note here is since 2014 and up to 2020, science has continued to evolve. And now some people, instead of taking this cutoff mark as 25% of glenoid defect, are putting it at 20%. Some European centers have also reported their cutoffs at 15%, but probably that is a bit too much on the other side. The jury is still out on what should be the perfect cutoff for doing a bony procedure. So I'll take you through a short video where Bankhart's repair and remplissage has been done so that you get some idea of what this surgery is all about. This is essentially for off-track lesions with less than 25% of glenoid bone loss.
This operation is performed in the lateral decubitus position. We start with a diagnostic round looking at the biceps tendon, moving on to check the cuff, and at the back we see this huge Hill-Sachs lesion. Our next step is to make an accessory posterior portal, and we debride the base of the Hill-Sachs lesion so that it is raw and made fresh. Then we establish our anterior portals, making sure of the angle of approach. We shift our scope to the anterior portal and then bring in a suture anchor from the accessory posterior portal The suture anchor goes straight into the base of the Hill-Sachs defect. The cannula is withdrawn outside the capsule. Penetrating graspers then come in, and sutures are passed at varied places in the posterior capsule and infraspinatus tendon. Care is taken in suture management. And after this step, we just leave the sutures parked in the accessory posterior portal, and knots are not tied. Then we move on anteriorly with a liberator. We elevate the labrum. Bone bed is prepared with a shaver on the glenoid side, as well as a soft tissue debridement is done on the capsulolabral side. Suture anchors are inserted onto the glenoid. Stitches are taken through the labrum and the IGHL. Knots are tied to ensure a good labral bumper with a good capsular shift. Then we again switch the scope to the anterior portal. The sutures that were parked posteriorly in the accessory posterior portal are then tensioned to make sure that when they are pulled, the entire posterior bulk of the capsule and the infraspinatus tendon fills the Hill-Sachs defect. There you see the effect of the pull. After this, knots are tied blindly because they are extracapsular, and this is what it looks like on the following day.
So that was a demonstration of a classic Bankart's repair and a remplissage. And some of our patients, this for example is a professional athlete, and they tend to achieve pretty much close to full ROM in all the cases. There is a big myth out there saying that if you do a remplissage, you severely compromise ROM. Our results haven't shown that. We've been doing it for the last 4 years. And another gentleman who's from the police. And they are back to pretty much normal functions. Studies have shown that there is some restriction in terminal elevation as well as external rotation, but they are well under 10%. So 5-7% of ROM loss can be expected, but that is a small compromise to get good stability in your shoulder. So to summarize, shoulder instability has two distinct parts, a soft tissue part and a bony component. The bony component involves the glenoid side as well as the humeral head side. Both can be quantified by the glenoid tract concept. That is one concept which has united all the bony factors on shoulder instability. And for Hill-Sachs lesions which are engaging or off track, we need to do something about the Hill-Sachs, and that is typically add a remplissage procedure to your Bankart's repair and you will have good results. So this is another of our patients. He is now trained on to become a gym instructor. So thank you very much for your attention.